So today we're going to talk about the CTG NICE Guideline that came out from in 2022. But before we start, really good idea to talk about something we talk very less about, and that is our workplace environment. Most of us think that the path is very linear and it's really straightforward, but I think it's worthwhile just taking a minute and looking at it in a bit more depth before we get on to the CTG itself. So, if you're working as an Obs and Gynae registrar, and if you're able to enjoy your work, that is the key starting point in terms of a healthy workplace environment. Because if you're able to enjoy work, you will automatically have a degree of motivation. This is the bit that gets you up in the morning and you think that you can contribute, you can help patients. If you feel that you are motivated, the key thing is that you will then be able to work at your fullest potential. Like Emma Watson said in the movie The Circle, her biggest fear was being in a job where she has unfulfilled potential. So, that being the key thing, if you feel that you're at work and you're able to get maximum potential, you will have a better degree of job satisfaction and you will be at your best possible optimal balance in terms of work. And you've got to recognize that mine, yours, somebody else's will all be different. So the key thing is that you have to be your own best. And if you are able to achieve that, you will be automatically translating all of that into the duty of care that you can give to the patients. However, the ability to enjoy work is not a given. If you're an Obs and Gynae registrar, you work for us in our department, I can't expect you to come and enjoy work. Some things need to happen to allow that to occur. So one of the basic things is knowledge. Knowledge is very individual. You'll have to work to establish that, and it's a very important fundamental thing that is a strong foundation. So you need to read your texts, literature, exams, everything else to get a good grounding. And that then allows you to develop skill, which is something your department needs to provide for you. So you have to have the opportunities in theater and otherwise to learn the stuff that you need to. That also, these two need to have an adequate amount of resource. And when we say resource, we're not just talking about the equipment or instruments and things that you need, but also human resource. So we're talking about good staffing levels, so your rota is fully adequately filled, theater nurses, midwives, everybody has to be there to allow you to be able to develop. And lastly, the important thing is that you need to feel that you are adequately compensated for the work you're doing, an ongoing thing right now in the NHS. But there we are. So if you are able to have all of these, it's not difficult to imagine that as a registrar, you've worked hard, developed the knowledge that you need to have, gained the skills that you need to use. You are in an environment which has adequate amount of resources, and you feel that you're adequately compensated for it. You are probably in a really good position in terms of being able to enjoy your work and everything else that follows from it, eventually leading to the best duty of care that you can provide to your patients. Now, you already have recognized that a lot of this stuff is a whole series in itself. Some of the things are not so simple, like these bits here. These are the soft things, talked about less, taught about less, and considered less when you're in your workplace. The compensation and resource side of things is also not your problem. Your deanery, the trust that you work in, and the government in general have a responsibility to ensure that all of these things are in place. But the knowledge and skill, that's the bit that you need to work on and develop with assistance. And that is going to be our sort of area of emphasis. And the simple reason is that knowledge is power. So if you have the knowledge and the skill, you will develop a comfort zone. And that comfort zone is something you can then expand as you move through your career, so that you can learn more and more things that you can do and gives you a degree of satisfaction about progression. Automatically, that level of comfort leads to a higher degree of patient safety. So patients under your care, when you've got adequate knowledge, skill, resources, will have a high degree of care, and that is our ultimate responsibility. Also, following on from that, more importantly, as you become more senior, you have a leadership role and also a teaching role. And in the right environment, you can take on these responsibilities and offer your teaching to the juniors who are coming through. And that's what brings us to our CTG monitoring. So this is only a very, very small part of the knowledge and skill that you need to have. And that's what we're going to concentrate on moving forward. Right, so there we go. That's our flowchart, which has a sort of an overview description of the guideline. Is based on the NICE guideline, so there's nothing in there that is out of the guideline. And the layout is very simple. You got all the features at the top, and then how those features can look like in individual patients, and how you're going to use that to interpret it. Two important things before we crack on. So the first one is that this is based on the NICE guideline. So as you know, in UK, NICE is our national body that produces guidelines, and it's very good. They encompass a lot, but there are lots of limitations to NICE guidelines, particularly that in a social medicine kind of picture, like in the UK, NICE guidelines do have a duty to be cost effective, and that needs to be borne in mind when you are looking after individual patients. The other thing is that it is a guideline, so that is exactly what it is. It is a guide for clinicians to help us decide what would be the best for our patients. This is not the same thing as a policy, which is much more prescriptive, and deviations are not not normal. Whereas with a guideline, you have to keep the patient in the middle of your care. So it all never to forget that we must deliver patient-centered care, and the guideline is there to help us ensure that we are providing what is best for our patients. Automatically, what flows from that is that although we have a guideline, we mustn't take our eye off the clinical picture. So take everything into account: patient wishes, the knowledge you have from patient history, and so on. And that's what makes the guideline most useful, in that you can mold it to help your individual patients. So that's a bit about the guideline. And the other bit is that it is a relatively new guideline, December 22. So it's very important for us to know and apply this in our day-to-day work. And the final bit is that it is fetal monitoring in labor. So we can do a whole talk on what it should be called: electronic fetal monitoring, CTG, what about STAN, and all of those things. So that's that. The other point we want to make sure is awareness about what we won't be discussing. So we won't be talking about the basis of CTG to start off with. I have to assume that you know what all these terms mean and the interpretations of that. We won't be talking about fetal physiology. We may touch upon it just very slightly, but that's not the topic of this conversation. We also won't be discussing controversies about CTG. So we all know it was not an evidence-based tool. It was ushered in as soon as it was felt applicable, and there's a whole debate about that, but we won't be going into that. We also won't be going into the basis for these NICE recommendations. There's loads of stuff always to talk about in NICE. For example, where did the 50 minutes come from? Why have we gone with white, amber, and red? And so on. You can nitpick every little bit, but we won't be doing that. We will take guidelines as they are, accept them as truth, and move from that point. And lastly, limitations of guidelines, which I've already just touched upon. So there we go. That's time to get our hands dirty. That's the flowchart. It is really easy, and I'll simplify it even more. So in the next sort of 5 minutes, you will have mastered CTG and labor ward management based on CTG. So those are the key features, and these are all the ways things can look like. and from that we'll follow on to what we class as pathological, and then move on to what intervention is needed. So let's start at the bottom, really. All the times that you will want to look at a CTG, or you'll be asked to look at a CTG, is to answer the question, do you need to intervene? Does this baby need to come out? Okay, and the whole thing rests upon whether or not you need to expedite delivery. If this baby needs to be delivered, then you've got to act on that. If you think that that's not a concern right now, you can decide to wait, and that will be 5 minutes, 15 minutes, 30 minutes, whatever. The only two ways baby can come out is C-section or a vaginal delivery, and a vaginal delivery, it would be an instrumental in your case, and those are the only two outcomes. So your job is to look at the trace and decide whether or not you need to intervene. If you do, if there's full dilatation, you want to do an instrumental delivery, so you've got to be good at that. If the cervix is not fully dilated, you need to think about a C-section, and you've got to be good at that. And if you can deliver these two outcomes and you're skilled at that, that's it. Whatever the interpretation of your CTG, you will be able to act on that. So that's the bit about expediting delivery, which is the key feature here. Now, the guideline wants you to always institute conservative measures, and these are things you already probably know, that we are IV fluids, left lateral position, remove the provocative factor that might be causing concerns on the trace. So, for example, sepsis, temperature, dehydration, whatever it is, you try and fix that, and institute these conservative measures. Obviously, you also want to look out for quad prolapse, APH, and things like that. So, any other factors that weren't there to start off with. Fetal scalp stimulation is now recommended, and if you get an acceleration on the trace after fetal scalp stimulation, that's good evidence that baby is fine. FBS is now out. 0.1, 0.7 in the guideline says they can't make a recommendation about an FBS, which means really that don't do it. And there we go. So those are the things that you need to do. So yeah, fetal scalp stimulation, and if you get a good response, great. If not, you've got to think about expediting delivery. Obviously, you only take the measures if you have time. If it's concerning, then you've got to just act. So what do you do? So let's start with bradycardia, because this is the easy one. So bradycardia, more than 3 minutes, would be this trace that the fetal heart drops and it's just taking ages to come up. And yes, it is a panicky situation. You've got to really act and do 20 things at the same time. But from a decision-making point of view, diagnosis is fairly clear. It's really easy to reach. You've got a bradycardia, 3 minutes, you know you've got to conservative measures immediately and think about expediting delivery. So vaginal examination and check fully dilated, think about an instrumental, can you do it? No, think about C-section. So from a decision point of view, bradycardia, although it is stressful for everybody involved, is straightforward, and you know you've got a diagnosis, you know what to do with it. Decelerations, on the other hand, are a completely different kettle of fish. So this is where all the controversy is. These are the things that get discussed at perinatal meetings. So with decels, there are only 6 things that you need to know, and that is really the key thing here today. If you get those, you're a champion. So 2 types of decel: early and late. Early and lates are not common. Okay, but those are the ones that we will quickly discuss. Earlies are the ones where you've got deceleration exactly in sync with a contraction, and they are really easy to spot. They always do that, and that's an early. They're not that common, but if you see them, you'll know. Lates are also very peculiar in that, firstly, they always mirror images of themselves. So they always look the same, because it's the same provocative factor that is causing the baby's heartbeat to go down. Then the other key feature with lates is that they're always the same distance away from the contraction, because that's the same insult occurring every time, and that's causing the baby's heartbeat to go down. So lates and earlies have got very specific features, and you got to know how to recognize them. Variables will make the bulk of the decelerations you will see on the trace. And the only thing you need to know about variables are concerning features. So the guideline, they've changed over time compared to when I was a registrar, but currently guidelines have 4 features. The first one is a variable decel that lasts for more than 60 seconds. Second is loss of variability. So that's probably what it looks like. You're a decel, but there's no variability within it compared to before when it looked like that. And if a deceleration is sort of changed in character from having some variability within a decel, then that's concerning feature. Loss of shouldering is the other one. So if you had, let's make a better one. So there you go. That's a deceleration with shouldering, and if that becomes a deceleration, a lost shouldering, that is also a concerning feature. And lastly, the fourth point is of a slow rising baseline. So a slow rising baseline would be a deceleration that was initially normal, but now the baby is really struggling to get the heartbeat back up after a contraction or around a contraction. So these are 4 concerning features, and that's it. If you know these 4 concerning features, you know what an early and a late is. That's it. That's all you need to know really about a CTG. And how you're going to interpret this is very, very simple. The first thing you want to ask when you are interpreting a trace is whether or not they are repetitive. So repetitive is more than 50%. Now the guideline has not given any clarification on what should be repetitive. Should it be based on time, so over 10 minutes, 15 minutes, or is it based on the number of contractions and how many contractions you need to clock before you call it repetitive? Should it be 2 or 6 or 8, 10? Doesn't say. So you will have to use your clinical judgment on deciding whether or not decelerations are repetitive, but you'd have to spend a certain amount of time to decide if these are with more than 50% of contractions. If you see deceleration, you call it repetitive, then you proceed to the next step. If they're not repetitive, then that's not so much of a concern. That doesn't mean walk away, but you have time. The next question you want to ask is, if they are repetitive, is have they lasted for more than 30 minutes? So if they're not lasted more than 30 minutes, again, that's not an immediate concern. You still need to be vigilant. But if they are more than 30 minutes, then you want to look for the key features. So are they late, or are they variables with concerning features? And if they are either late or variable concerning features, you've got to get your conservative measures in and think about expediting delivery. And that is it. That is all there is to interpreting the CTG, right? So firstly, whether or not they're repetitive. If they are, have they lasted for more than 30 minutes? If they have, do they have any late features or any variable concerning features? And if it's either of these, that's a pathological trace. Conservative measures, if you have the time, and already think about expediting delivery. Now, in obstetrics, obviously everything is dynamic, so things can change, but that's the thought process you need to have. And we've already established that if you're able to expedite delivery quickly, you're fine. Now, that's not all there is to it. There's some nuances. So variability is one of the things, and the guideline says if you have more than 25 variability for more than 10 minutes, or a sinusoidal trace, or it's less than 5 for more than 50 minutes, that's all red. That's all pathological. And again, you follow the route to what you do with pathological traces we discussed before. Also, 2 ambers make a red. So any other feature apart from these 4 things that we discussed in our decision making, that's an amber. All right. And if you get more than 2, you got to think that this is red, and you start thinking about some kind of intervention. Now, bear in mind that this is not an exact science. This is the best we've got. Okay, so be mindful of that. Good luck. Put comments below, and we'll bring out more stuff in the near future. Thank you.